PT Brand Rounds for the year, so it will start up again in January. It'll start being the second Wednesday of every month. Today we have Dr. de Blasio talking to us. He received his Bachelor of Science and Doctorate in Physical Therapy from the University of Delaware. He is board certified in orthopedic physical therapy, and he's certified as a strength and conditioning specialist. He is core faculty in the Orthopedic Physical Therapy Residency at St. Louis University Health Network and has been an invited speaker on the topic of gastrointestinal disorders throughout the Northeast region. He is our facility director for our Orfield Clinic and practices there as well. So just make sure that you sign in to get CME or CE credit. And if you're from New Jersey, also make sure you sign out. And also make sure you see me so I can scan your badge on your way out. And people who are watching this online, you'll be receiving an email from me within the next week or so about how to claim credit for this. There will be a quiz online on my email for everybody. So without further ado, Dr. de Blasio. Woo.
All right, thank you guys. Appreciate you guys all showing up today. It's a kind of a unique topic. I think within the network, there are, I believe, some therapists treating GI disorders. But hopefully today shed some light on what we are doing with these patients in this kind of niche practice. As Steve mentioned, I am the facility director at our Orfield office. I've been there for 11 years now. I did receive my OCS in 2011, and I went to the University of Delaware, graduated there in 2005. This designation statement and our disclosure information, I have no financial interest in. Today's objective, so hopefully by the end of today's lecture, we can identify patients that may be coming to us for an orthopedic condition and have an underlying gastrointestinal disorder that may be either referring pain within the body or just something that is bothering them that they didn't know they had the ability to seek out PT intervention for. We'll take a look at some studies that talk about cases, and then we'll discuss some treatment options that we do with these patients as well. So background on this. I have read visceral manipulation and have taken some courses. I have not yet taken anything from the Burrell Institute, but that institute focuses primarily on visceral manipulation and treating, the viscera for patient symptoms. The IPA is an organization which I've taken extensive work through, who talk about visceral manipulation and teach how to identify visceral restrictions in your practice. So I started experimenting with some of the lessons that I was taught in these classes on patients. And I'm very skeptical at first. I have to be honest. You hear these things and you kind of go, okay, is this really going to work? After about a year and a half of practicing and including this, incorporating into my practice, I was able to give a grand rounds presentation on some of the success we were having. We focused initially on the brain-gut axis and how that relates to migraine and headaches, and being able to identify if there is a patient who's suffering who has not yet explored the option of whether or not these gastrointestinal disorders have an effect. Have you ever heard of abdominal migraines before? I've heard of that. So this lecture primarily focused on exploring the relationship between the GI disorders, headaches, and migraines, focusing on how vagus nerve dysfunction, which we're going to get into a little bit later in the presentation, can cause numerous symptoms, including headaches and migraines, or contribute to. Seeing some patients and then having them see their GI doctors and giving positive feedback, I went ahead and I was working closely with one of the PAs, and I asked that PA if there was an opportunity for me to talk in front of the GI group. And she reached out to Dr. Noel Martin, who is the chief of the department, and he works with all the fellows. And he said, yeah, we have a fellowship monthly meeting When fellows meet once a month and we go over a new topic or something that they're interested in, he said, I'd love to have you. So we went there and we discussed conservative measures for these GI patients, and something that they might not have been introduced to before. And since then, I've met with each of the offices on a smaller scale and talked to all the clinicians and the PAs, office staff, as well as the residents and fellows. When I first sat down and talked to the PA that I was working with, we tried to describe patients that may benefit from seeking out a consultation with a physical therapist. We describe them as no-hope patients, and anyone who's treated patients before knows what can identify a no-hope patient. You try things, and nothing's working, you're not sure why you're not responding. So in this example here, we said, they had a scope, it was negative. Their diagnostics were all negative. Trial of medications, unsuccessful. Dietary changes, not working. Normal blood work, no referral necessary, or they were cleared by their specialists. So now what? You're sitting across from a patient and you go, I want to try more meds. Well, if you try more meds, there's a side effect. PPIs are a common medication that is prescribed to GI people who are suffering from GI disorders, specifically like GERD, acid reflux, and those have side effects. The more you take them, they've been linked to having osteoporosis. So people are hesitant on taking them. Invasive exploratory surgeries. I'm not signing up for one. For a doctor to say, I'm going to cut you open, and we might find something, we might not, and then we'll close you back up. Well, that's been shown to cause scar tissue, which causes potentially more problems in the future, right? And then you risk infection. You risk complications of going under anesthesia. So this is not something new to gastroenterology. It's actually described as functional gastrointestinal disorders. They're characterized by chronic abdominal complaints without structural or biochemical causes. Okay, so these no-hope patients that we identified are grouped under this functional gastrointestinal disorder. They involve visceral hypersensitivity, motility disorders, brain-gut dysfunction. More than 20 of them have been identified, and most common are irritable bowel syndrome, constipation, and dyspepsia. These functional gastrointestinal disorders, or FGDs, are described in what's called the Roman criteria. Okay? It's actually the 4th edition, and the last one was published in 2016. And it's an international effort to create a scientific database to help in the diagnosis and treatment of these patients who suffer from functional GI disorders, or now known as disorders of the brain-gut interaction. Okay, so it's really neat. So in our network, these conditions have not been addressed with physical therapy or conservative measures like manual therapy in the past. Within our network right now, there is a study going on. It's one of our PT residents, along with some of the primary care residents. And what they're looking at is prevalence of comorbidities related to movement. And is there a strong correlation between any one or several comorbidities that may influence needing a movement analysis suite, which is the APTA describes the movement system as a collection of systems that interacts to move the body or its component parts. And that includes cardiovascular, pulmonary, endocrine, nervous, musculoskeletal. Okay, so it includes everything. What they did was they had patients fill out a one-page data when they went through their appointment. And in that, this is, the questions that they had was, do you have pain or difficulty when starting or performing any physical activity? And then have you spoken to a physician about this? Why or why not? When they filled this out and they were included in the data collection, their comorbidity data was obtained through the EPIC chart and reviewed afterwards, okay? So as shown in the table, GERD ended up having the highest p-value. Okay, so based on the data collected, a systemic movement dysfunction is highly correlated with having GERD. And that's ahead of arthritis and ahead of obesity. It's pretty powerful. When we're doing this within our own network. Steve Ferrer was able to tell me about this. I had no knowledge of this when we started talking about this topic as being something that we're going to, kind of push forward with. And I thought it was really interesting. So we don't know if it's the GERD that causes the movement dysfunction, or the movement dysfunction that causes the GERD, but there's enough correlation here, enough strong data being collected that it warrants patients who have these comorbidities, or this comorbidity, GERD, to possibly go for a consultation with a therapist for a movement dysfunction analysis. I think that's pretty cool. It's pretty powerful. Going back to the GI. So these are the
Sounds like good.
Want me to continue or just wait?
Go ahead.
Okay. I'm fine with time, so.
Yeah, keep talking.
Okay. So what you saw up there right now, the last slide, was all the protocols that the gastrointestinal department tries to follow. For each diagnosis, they do follow a protocol so that basically the treatments within the network is basically the same through providers. It's a guideline as opposed, it's not black and white. But in those protocols or in those cascades there, they do describe activity modification, they do describe lifestyle changes, okay. But they do not put in there conservative measures like physical therapy. So with the research that we're doing within the network and some of the talks I've been having with them, we're hoping to get included in their protocols, okay? Which would be phenomenal for us. So now all the physicians are starting to think, well, if I'm having these patients who are not responding, these functional gastrointestinal disorders, should we refer them to therapy? Can they help? So far, they've been pretty receptive. I have some numbers up there, so don't quote me. In 2018 fiscal year, I think there was like 15 referrals, and then 2000 And so we've had 39 referrals to just PT since June 13th. That's pretty good referrals. Yes.
Do you only do it at Warfield?
Right now we are, but we are actually mentoring clinicians now to start providing services elsewhere. We're trying to get it, maybe 3 or 4 offices that are doing it. And that's going to happen over time. This is really new. This is new to the network. So we're really trying to build that trust and rapport with the physicians. And as we do that, hopefully we see a continued increase. Therapists within our network as well have sent patients to me at my office. So far we've had 8 since June 13th, and 100% of them have attended. So it seems that when a therapist recommends it, they're all in because the therapist is able to say, this person's been helping some people, I think you should go. And then proximity too has helped as well. What conditions have you treated? So I would say successfully, because these are very complex patients at times. Some of them have been treated completely successfully, discharged and out. Some of them are what we consider maintenance patients, maintenance program patients, where they come maybe once every week, once every 2 weeks, once every month. All right. But GERD, acid reflux, gastroparesis, constipation, hiatal hernias, irritable bowel syndrome, dyspepsia. I've worked with patients who have had abdominal surgeries where they have scar tissue and maybe abdominal pain as a result of it. Chronic cough, headaches, and migraines. Just recently, we had a case that just came in. She had a surgery to remove an ovary on the left side, and she developed severe scar tissue and adhesion on the right side, where she couldn't actually get up and function without severe pain on the right side. So why? I don't know. But she came in, we treated her. She's come to 2 sessions. She has come to 2 sessions. Her pain is dramatically decreased from just doing some visceral mobilization, and she's more of an orthopedic patient at this point because it is soft tissue and muscle spasm that we're treating. It's pretty neat stuff. The next section of the lecture, I was trying to break this apart, but I feel like I couldn't. So we're going to talk about what we do in the consultation. While we're doing that, we're going to review the relevant anatomy. And then I'm going to point out some of the literature that I've read that supports some of the treatments that we're doing with these patients, or why we're evaluating these areas. So when I have a consultation, the first thing we're doing is we're contacting them to answer any questions they have before they drive to see us, because a lot of them are apprehensive about why. When we do our history component, linking events, people may not realize that their underlying GI or their GI issue is underlying orthopedic issue. So we try to look at, has there been any trauma, motor vehicle accidents, infections, surgeries, or just injuries that may have preceded when their symptoms started. So it's really important to get a very thorough history. And a lot of times after you start working with people, they'll be like, you know what, I forgot to tell you. This happened, or I did this, and my symptoms started thereafter. And then screening of other systems as well. The patients that are coming to me for the most part have seen a GI specialist before, but if they haven't, I consider referring out to get screened. So the gastroenterology department has specific red flags. If a patient comes in and they have an onset of reflux and they're greater than 60, it's an immediate referral to GI and a scope to rule out cancer. So we have to stand by what they do within their own practice. A new onset of constipation over the age of 50 is an immediate referral for a scope. And if they're between 30 and 50, referral to GI, medication trial, and then they'll scope when they feel necessary. So if I am getting patients that have not seen a GI specialist, I'm kind of hesitant because I know the limits and the scope of my practice. I want them to at least be seen by their primary or to then go see a specialist if they're comfortable doing that. There's some additional red flags. Patients are coming to so some additional red flags here. These are like things that would stand out in an evaluation that may require you to say, I can't see it today. We'll go see a GI specialist and then we'll continue. All right, so now during the evaluation, posture is huge. Okay? Evaluate everyone to see what kind of posture they have. We all know from an orthopedic standpoint that posture can cause issues, musculoskeletal issues, pain, and just overall dysfunction. But how does that relate to the GI system? Well, let's just look at the esophagus as an example. Okay, so in these pictures, as they go across, the one farthest to the right, I would imagine that the esophagus it's an appropriate alignment. Okay, so food gets swallowed and it goes down to the stomach. And if you look at the different postures on there, how does that change? How does that pathway of food going from the mouth down to the stomach, how does that change? And could that cause any stress? So identifying someone's posture and then working on normalizing their posture would be the first step. Looking at cervical range of motion, lumbar range of motion as well to see if there's any significant limitations. Neurodynamics is really important. We have to clear upper and lower extremity neurodynamics to make sure that tension is not causing there to be limited ranges of motion that could be contributing to these GI issues. Cranial nerves, okay? Screening them is really important when we're dealing with GI issues. Specifically looking at 3 nerves, the gastropharyngeal and vagus nerve. And those are tested by the Ah test and the gag reflex test. In the Ah test, you're looking at the uvula to see if it's deviating to one side, which can tell you have a dysfunction. And then the accessory nerve, which innervates the cervicotiomastoid and the upper tract. It's important to know the difference between the parasympathetic and the sympathetic nervous system. Okay, the autonomic nervous system is comprised of 3 parts: parasympathetic, sympathetic, and enteric nervous system. And enteric nervous system is the nervous system of the gut. Okay, it sends feedback to the brain about the state of the gut. The autonomic nervous system is basically involuntary, and it kind of regulates the entire body. So any dysfunction within that nervous system can cause there to be dysfunction and you don't have homeostasis in the body. For example, sympathetic nervous system is fight or flight. Parasympathetic nervous system is rest and digest. You don't want to have either one be hyperactive. So they work equal and opposite of each other. If you look at just the stomach on there, you'll see that the vagus nerve stimulates peristalsis or motility, in the stomach, and then the sympathetic nervous system slows it down, it inhibits it. So they work hand in hand. They have to work together. If one's not working, you're going to have overproduction or underproduction. You understand? Vagus nerve, I think, is one of the most important nerves to consider. It provides parasympathetic control to the viscera, and understanding its anatomy and where where there may be problems that arise with it is really important. An underactive one can cause gastroparesis, and an overactive one can decrease heart rate and cause people to faint, right, or vasovagal syncope. Other symptoms of vagus nerve dysfunction are dysphagia, hoarse voice, inhibited gag reflex, uncontrolled inflammation, rapid heart rate, anxiety, depression, abnormal blood pressure, production of stomach acid, we just touched on, nausea, vomiting, and abdominal bloating and pain. It's important to know where it originates from. So if we go on here, just press this button. So if we come up here, this is the foramen magnum, and out of here comes our spinal cord, okay, the brainstem and the spinal cord. And right over here is your jugular foramen. So this is the jugular foramen here. Oops. This is your jugular foramen here. You can see there's 3 nerves coming out. Okay, the 3 cranial nerves we just discussed. Cranial nerve 9, 10, and 11. Right here, you see this is a synapse here. Okay, this is a ganglia, okay? And the accessory nerve and the vagus nerve have a common link here. Okay. So I'm going to stick on that last picture for a minute. We all know the brachial plexus, and we know that as the cords come out. Back to the visual. So the vagus nerve basically comes out of the jugular foramen, which is, if everyone knows where the mastoid process is, so it's kind of like right through there. Comes down slightly anterior to C1, the transverse process of C1. C1 sticks out, it's kind of right underneath your mastoid process, so anything just anterior to that. If C1 has any dysfunction to it, doesn't move correctly, it's going to put tension on the nerve. Okay? In the lumbar spine, or the cervical spine, we're very familiar with where the nerves exit the spinal cord. And if the space that they have to exit are compromised in any way, you get peripheral symptoms, correct? When you're talking with cranial nerves, the peripheral symptoms you may feel may not be pain all the time. It may be something systemic that can contribute to dysfunction of the organ, or can go dysfunction to whatever that cranial nerve innervates. Can you follow me on that? So when we're talking about treating these GI patients, there may be an underlying cervical issue or lumbar issue or underlying musculoskeletal issue that needs to be addressed to take tension off of a nerve. If there's adverse neural tension on a nerve, it's not going to respond appropriately. We already know that because we treat that in our extremities all the time. But when we're talking about cranial nerves, or nerves that are part of the autonomic nervous system, they're not going to be pain. It's going to be other symptoms. But just open your mind to that concept. So we do, from a treatment standpoint, we'll do upper cervical mobilization and manipulation to try to restore what we call getting the upper cervical spine on alignment or on axis. And then we talk about, great, let me go back to these pictures. So this is the one we talked about, crossover. And then here's the cranial nerves, the 3 of them exiting the jugular foramen out of the brainstem. And here's a picture of C1, okay, and its relationship to the vagus nerve. See how close it is? So if you are off axis, if there is a dysfunction or there's muscle spasm in that area, you're going to have a compromised vagus nerve. If you have a forward head posture, how does that affect it? If you have a retracted head posture, how is that going to affect it? All right. And then this is just a good illustration of C1 being off axis. Okay. And on the right-hand side, it shows if I have a postural dysfunction, how does that affect the upper cervical spine? So it leads us to what's non-specific neck pain. So neck pain without associated with any specific underlying systemic disease is considered non-specific neck pain. And it can be poor posture, anxiety, depression, cervical tension, and or it could just be multifactorial. There's a study we're going to talk about later in the presentation, but it has been hypothesized that the anatomical relation between the accessory nerve and the vagus nerve may contribute to non-specific neck pain. Right? It is innervating the upper tracts, and people are just having generic, generalized neck pain. If we don't rule this out, it could be a possible cause. So we'll look at a study in a little bit on that. It's also important for us to consider the tongue, the hyoid bone, the larynx, the esophagus, and the trachea. How do they move? What's the mobility like in there? And how those structures can influence, these GI dysfunctions. We evaluate and look at the anterior cervical spine muscles, specifically longus capus, and this scalene, looking for tightness and weakness in those. This is a picture of the thoracic girdle. The thoracic girdle is compromised of the sternum, the manubrium, clavicle, ribs 1 and rib 2, the upper thoracic spine, T1, T2, and you also have the brachial plexus passing in that area, which can contribute to thoracic outlet syndrome if there's dysfunction. Green nerve descending is the vagus nerve. So you can see it. If we have an issue with anterior cervical spine muscles or malalignment, that nerve can be influenced at that location as well. And then that vagus nerve travels down through the thorax and goes into the esophageal hiatus, which then innervates the stomach. So the vagus nerve actually wraps around the esophagus. So if it does have dysfunction, you can see how that may influence the vagus nerve. Picture the diaphragm looking from bottom up. You can see the esophageal hiatus here. Okay, down here, basically the level of the TL junction, thoracolumbar junction, and then you have your psoas muscle coming up and your diaphragm attaching to the spine in the center. So really critical point of the body where a lot of transition happening. We know there's a lot of shearing forces going on in the lumbar spine at that location. And how does that influence the diaphragm, or how does the diaphragm influence that joint? This picture here is of the esophageal gastric junction, okay? And this is the lower esophageal sphincter. And this over here is the crural part of the diaphragm. The crural part of the diaphragm is critical to patients who suffer from GERD. Right? It's under vagal control, meaning that the vagus nerve innervates this portion of the diaphragm. The diaphragm is primarily innervated by the phrenic nerve, so this portion is primarily innervated by the vagus nerve. So the lower esophageal sphincter is smooth muscle innervated by vagal efferent nerves, supplying both excitatory and inhibitory responses, and acting as a primary mediator of the reflex, which is the closing and opening. And the crural diaphragm basically surrounds the esophagus, and if you don't have good mobility or good function of the diaphragm, then that crural portion of the diaphragm is not going to assist the lower esophageal sphincter working the correct way, right? Or if you have dysfunction of the vagus nerve. Here it shows the innervation of it. You can see how you have the vagal nerve coming down and then innervating the lower part. And then you have the phrenic nerve coming down and innervating the diaphragm. GERD is basically when that lower esophageal sphincter is not working correctly and you get stomach acid coming back up, acid reflux, and you get regurgitation of food as well. And then another symptom that these patients suffer from is a hiatal hernia, which can be what we call sliding or permanent. So a sliding hiatal hernia will actually slip up and slip back down, depending on the pressure within the thorax. So if you have a diaphragm and a crural diaphragm and a lower esophageal sphincter that's not working, it'd be easier for the stomach to rise through, and that hiatal hernia can cause a lot of symptoms, heartburn, chest pain, abdominal pain, acid reflux. Okay? Anyone who's ever suffered from it does not enjoy those symptoms. We'll look at a few studies out there. So how does, this first one is, how does osteopathic manipulation therapy in patients with GERD work? Or what kind of effect does it have? So this was a single-blinded study. And these patients were all diagnosed with GERD at least 4 years ago. They underwent treatment, 3 sessions focusing on just mobilization of the esophagus and the diaphragm. And they used a outcome measure called QS-GERD, which is a 6-point scale, and 0 means that you have a great quality of life, and 45 means you have pretty poor quality of life based on your symptoms. What they were able to show is that manual therapy applied to the diaphragm and the esophagus improved symptoms of GERD and should be considered as part of a somatic visceral approach in the care of patients. Another study looked at just soft tissue work to the diaphragm. And this was a randomized controlled study. It was published in scientific reports. And it basically looked at whether or not PPI usage would be affected by mobilizing the diaphragm. So the group that had the mobilization of the diaphragm had a decrease in GERD symptoms and a decrease in usage of PPI. And that was true up to 4 weeks after their 3 treatments. Interesting. So it brings us down to the viscera, okay? Basically all your abdominal contents, okay, all of your organs. Knowing the visceral referred pain patterns is important because if someone comes to you with non-mechanical pain and they're complaining of pain in a specific spot, it's really important to know where that may be referring from in the viscera. A great little slide showing where those referral pain patterns may be. And if you look at just the stomach, you have midline low thoracic and may also refer to the right shoulder and neck. But it's really important to know where these referred pain patterns are within the body so that if you have one, you can identify it. And that may be a reason for referral. So visceral manipulation, I'm not sure how familiar you guys are with it. It's really specific gentle soft tissue mobilization technique focusing on resolving adhesions and tissue tension, thus improving tissue mobility. If we have adhesions within the abdomen, how do those organs move? Do they move fluidly? Two organs should move independently of one another. Okay, they should not move together. They each have their own three-dimensional mobility. And if there are adhesions between the two, or just adhesions within the organ itself, what kind of symptoms does that create in the patient? I pulled up a short video just kind of describing what is visceral mobilization. in the musculoskeletal system, we do this all the time. We have tissue breakdown, we mobilize it, and it starts to heal and improve, right? So it's the same principle applied to just different tissue within the body. That tissue within the body that you're applying visceral mobilization to does not respond the same, does not cause the same type of symptoms that muscle and joints do. So those are the symptoms techniques. Abdominal adhesion is a small bowel obstruction. This is where visceral mobilization can be really effective. The standard current treatment for small bowel obstruction due to adhesions is surgery. So if you have adhesions in surgery from a previous adhesion or surgery, they then go in and remove the scar tissue, which then eventually creates more scar tissue. Okay. And there's high risk involved in having that kind of surgery. So they did a study out of the Journal of Clinical Gastroenterology where they did a laparoscopy on chronic abdominal pain. 72 patients underwent surgery. 85% of them were found to have had adhesions. Okay? Not all of them had been necessarily the source of symptoms. However, after a result of 3.5 years, or a little over 3.5 years, 33% who underwent the treatment were totally pain-free. 21% had no improvement. 46% had less pain. But they also had all those risks associated. In the World Journal of Gastroenterology, a study was published. It was a controlled study. There was 103 subjects in the history of recurrent small bowel obstruction. They were treated in therapy for 4 hours over the course of 5 days, which is part of the study. It's not typical. 136 subjects were in the control group and did not receive any manual therapy. What they were able to conclude after 90 days was that there was a significant improvement in reported symptoms. There was a lower reoccurrence rate. Typically, these small bowel obstructions, they occur kind of frequently, and you're not symptomatic all the time, but they continue to occur. So their reoccurrence rate was lower, and they had improved quality of life based on their outcome measures. In another study, we looked at evidence-based complementary and alternative medicines in an international peer review journal. And in this one, they looked at the effects of osteopathic visceral manipulation on cervical pain, cervical range of motion, and upper trap muscle activity. So this is going back to that previous slide that I had showed you where there was that crossover between the accessory nerve and the cranial nerve. So they had 28 non-specific neck pain patients who suffered from functional dyspepsia. And those patients were put into two groups. And the ones that were put in the treatment group received just visceral mobilization to the liver and the stomach. And that was it. And their outcomes were measured for pain, cervical range of motion, and the EMG activity of the upper trap. What they hypothesized was that nociceptive excitation due to modifications in function and movement of the abdominal viscera may cause nonspecific neck pain. So inhibition of that excitatory response may result in decreased neck pain. The outcome showed that a single treatment of visceral mobilization for the stomach and liver reduces cervical pain and increases the amplitude of the EMG signal on the upper trap. And that was immediately after the treatment and 7 days after the treatment. And that was just one treatment. The rationale behind that is afferent stimulation produced from restrictions of the mobility of tissues innervated by the phrenic nerve, which innervates the diaphragm and the liver capsule, could promote facilitation and irritability of neurons at the levels at which their neural roots are found, between C3 and C5. The other one could be what we talked about, the anatomical relationship between the accessory nerve and the vagus nerve. This goes back to that picture. This shows that accessory nerve with its origin. It has spinal origin and medullary origin, passing through the jugular foramen and having a synapse at the superior ganglia of the vagus nerve. Therefore, it's possible to conclude, okay, we can't prove, but possible to conclude that visceral manipulation to the stomach and liver may provide inhibitory effects of the afferent input provided by the viscera during, resulting in decreased neck pain and increased amplitude of upper trap muscle fibers. Okay. Study is promising, but it does need a lot more proof in literature to make it concrete. Okay. When I first start treating a patient with the GI dysfunction, the first thing we look at is breathing. Even before I look at posture and cervical range of motion, I look at breathing. Diaphragmatic breathing should be something that occurs naturally, but through learned habits and modeling, we tend not to breathe through our diaphragm. because it requires your stomach to kind of stick out. And most people kind of hold in and suck up. Right? So they inhibit their diaphragm, and that inhibitory response to the diaphragm has a cascade of events that occur in the body that can be detrimental. But when you breathe, you take your breath in, the diaphragm should go from a position resting in the abdomen like this to flattening out. Okay? And you'll see a rise and fall of the abdominal contents below. This illustration shows when you do breathe up and down with your diaphragm, diaphragmatically, it stimulates the parasympathetic and sympathetic nervous system for their function and their effects on the heart and the stomach or the intestines. So during inhalation, the diaphragm moves down under sympathetic control, and the thoracic pressure decreases, allowing air to come in. And then heart rate increases, and digestive action slows down. So they're equal and opposite of each other. Heart rate increases, digestive slows down, that's under sympathetic control. And during exhalation, the opposite occurs, mediated by the vagus nerve, or the parasympathetic nervous system, and it slows heart rate and increases motility. So if we're not breathing effectively through our diaphragm, if we're not getting mobility of the viscera, we're not getting motility of the viscera, because we're inhibiting that, and that can have a significant effect on the patient's GI symptoms. So the benefits of diaphragmatic breathing are rest and digest. It's calming, so it can help people who have anxiety or depression. It lowers heart rate, lowers blood pressure, decreases muscle tension, increases blood oxidation, or oxygenation, increases energy and motivation, increases concentration, strengthens the immune system, and reduces hormones. It can easily be implemented. It's all it is education. And there are really no side effects or no costs associated. So when we talk to the GI, the gastroenterologist, we're teaching them this, and they're saying, wow, that is something that, would be interested. I'm not sure how that would directly affect them or what your results will be, but that seems, the approach seems very logical. Next video I have is an illustration of an MRI that shows how the organs move and how the thoracic cage moves in the body with every breath. Okay, so when you breathe diaphragmatically, what happens? See how much movement is going on inside you when you're breathing the correct way. If the diaphragm is not doing that, if you're not breathing through your diaphragm and you are just accessory breathing through your upper body, breathing like this, that is not occurring throughout the day. You probably take thousands of breaths a day, I would imagine, tens of thousands. So if we're not doing that, then the repetition is not there, then the mobility is not there. So it's basically like putting yourself in an immobilization cast or brace, and not moving that extremity for a long time and seeing how you respond afterwards. And typically we know that from a musculoskeletal standpoint. When we immobilize someone, they lose range of motion, they lose mobility, and then we have to get that back, correct? And we have to retrain them how to use that new motion. For any rate. So then we looked at a study out, it was a randomized controlled study out of the American Journal of Gastroenterology. It was 10 subjects treated with active breathing training and 9 controlled subjects. And they concluded that active training the diaphragm by breathing exercise can improve GERD symptoms. The non-pharmacological lifestyle intervention could help to reduce the disease burden of GERD. This study, the results showed a long-term follow-up after 9 months and showed significant improvements in quality of life and decreased usage of PPI for the subjects. Diaphragm and the pelvic floor are actually really supposed to work hand in hand. As your diaphragm contracts and puts pressure down into the abdomen, it causes a relaxation of the pelvic floor. If that does not occur, patients tend to have more of a spastic response to the pelvic floor, or they don't relax as well, which could lead to functional constipation. So if we're not breathing correctly, not putting the correct pressure on the pelvic floor and stimulating it, it can go the opposite way and cause it to go into spasm or into not being able to relax. So we looked at as many 50% of people with chronic constipation also had pelvic floor dysfunction. Now these patients I'm not working with, the ones that have severe issues with relaxation. I'll kind of teach them some things, but especially in women, we'll refer them out to a women's health specialist, especially if they'll need like a biofeedback in order to relax. We can't get it from neuromuscular education. But physical therapy in general has been shown to be very effective with the management of functional constipation. Through visceral mobilization, pelvic floor strengthening, neuromuscular education, breathing exercises, toilet habits, and lifestyle education, these patients who have functional constipation, which means they have no underlying systemic issues, can benefit from the management of physical therapy. And in this perspective, they said it is our perspective that physical therapy management can be effective first-line intervention for individuals with functional constipation. Right now, a lot of the patients in our network are not getting it. So when to refer? All right, so I have a patient who comes in and I'm seeing them for something non-related to their GI symptoms, but they may have back pain or neck pain. You're working with them, and you identify that they have some comorbidities. You can do your own movement analysis to see if there's something going on, and does that treatment that you work on have a result or have an effect on their GI symptoms? But if that is one of the major issues that a patient is having, and you've treated them successfully for their orthopedic issue, maybe it is time to refer out to see if we can maybe benefit them. So anytime you have a patient who comes in with a history of surgical procedures of the abdomen, in their medical history they have a GI dysfunction they've gone to their GI specialist, and they say, like, oh yeah, nothing helps me, that may be a good time to refer out. And then we welcome any therapist who does have a patient with that to come to the session and see what we are doing, what we're finding with these patients. We've had some pretty cool, I've had some pretty cool inbox messages showing me what patients are saying about their response to the treatment. So the PA that I work with, she's been sending me the communications of the patients who are giving her on phone call follow-ups, which is pretty cool. So first visit, feeling cessation of her hyaluronic kind of going away. The second one here, this patient was very chronic. She had irritable bowel GERD, nausea, vomiting, and epigastric pain it was chronic in nature. And she wrote this, nice testimonial saying that what we were doing was helping. I believe she got about 60% better, and now she'll just call us when she needs. Pretty neat stuff. So that's really what I have today. If anyone has any questions, I'm happy to answer anything. This is kind of new. I tried to bring you through my thought process and the rationale behind what we're doing and why. It's really hard to explain it definitively, like do this for this person. Every person is different when they come in. We have to evaluate them and see their response. Every little treatment is a mini experiment with the patient to see how they do respond. Just the other day, we had a patient who came in, a male, and he had constipation for like the last 6 months, and he wasn't responding to anything. First thing he said to me when he came in was, "This isn't going to help." And I said, "Okay, then it's not. That's fine. But are you willing to give it a shot?" And he did. He was very open to it. And in just one session, he went from not having the urge and having to use enemas to avoid to having the urge, and went 3 out of 4 days in a row. That's pretty neat. It's not resolved, but that just having the urge to go for someone who hasn't been able to, and they've lost that feeling of what's going on. He responded well to the first session. We'll see how he does. Does anyone have any questions? No, go ahead.
Yeah, two-part thing. Is there somewhere you would recommend to go to actually visualize the visceral manipulations, mobilizations, and just how to kind of go about starting with that?
Coursework?
Like videos, something like that.
You can go on YouTube and look at what this visual mobilization. I don't recommend anyone kind of performing, aggressive or deep tissue visceral mobilization without having an idea of what they're doing from being trained. Mm-hmm. Yeah, I think it's not you know, there's so many things within the abdomen that you have to be aware of and be careful of. So it really does require, I believe, a little bit of mentoring, whether that's through coursework or if that's through, you know, shadowing someone who has been trained in that technique. Right? So, you know, our office would be one of them that would be open to having people come in and visit and observe.
Which office is that? Is that Bethlehem Physical
No,
Therapy?
right now it's my office over in Northfield, PA, which is just north of Allentown on 309.
Okay.
Right now, we're the only office that's providing the service. There are women's health specialists throughout the network right now. I don't know exactly how many we have, but I think there, how many?
12.
12 women health specialists. So that could be a potential referral source. You know, we could refer to the women health specialist to address some of these issues.
So if we have patients in the office in GI that may benefit from
Yes.
this, the next step would be
Direct
normally put a
referral.
referral in.
Direct
just
referral to
to-
physical therapist. So now what's happening is anytime a referral goes in to, you know, our work queue, there's a referral to physical therapy.
Mhm.
I'm going into work queue on a daily basis and checking if there's any referrals from GI to PT. If there are, I'm taking the lead to call them directly and saying, hey, this physician recommended physical therapy. I'm the provider that's going to be evaluating you. Is that something you'd like to do? So all you have to do is put the referral into physical therapy. It doesn't even have to be site specific. No one else is pulling that work queue order out except for me.
And if we wanted to run a scenario by you before we refer, I mean, would that be appropriate, or would you rather just have the referral?
I can give you my card.
Okay.
I was gonna say, I know I saw a brochure floating around our Allentown office. Where can I get like a bunch of brochures that we can keep at all of the?
They should have one, but I can also have our marketing director drop them off
Okay.
to you, knowing that you guys need them. I'm actually going to be meeting with Dr. Kapoor on Friday, so I can bring them in.
Okay, perfect. Yeah, because then we can get them to the other offices because we obviously cover.
And I've met with each of the offices. So
Oh,
the
they should-
flyers floating around are because I had an in-service with all the offices. Now, not every provider was there, but
Yeah. Okay.
Anderson and Warren?
The only place I saw them was at
What's that?
Allentown.
Were you at Anderson yet?
Mhm.
Warren? Oh.
well, I think
okay.
when I went to Anderson, there wasn't a really good showing. I think it is what it is. We can always do it again. If there's an interest to have us come out and talk,
Yeah,
on
I
a
think
smaller-
we do for our nursing team because the
Yeah,
nursing team is
so-
who deals with a lot of the chronic patients that would probably benefit from this.
so I would say the office
Yeah.
manager, I can't remember her name off the top of my head. I know Michelle now.
Letitia's and Anderson.
So,
Yeah. I cover the whole specialty, so
Okay.
I can kind of tie it all together.
Leticia didn't know we were coming, so that was a problem when we went to Anderson.
Yeah, I
It
imagine
wasn't-
that would-
It wasn't in the schedule.
Yeah,
So I think having another opportunity to go
For
out to
sure.
Anderson would be great.
perfect.
So we can coordinate that.
And insurance covers it? I'm sorry.
Yeah. Yeah, insurance covers it.
It's not investigational, it's proven.
Abdominal
there's
pain,
no-
we can treat
Okay.
it.
Once you have more results, are you thinking about rolling it out to the PCPs?
PCPs that are located next to my office, just North Whitehall Family Practice, yeah, we have. Yeah, they know, but I still recommend referral to a specialty before we actually treat them, just to make sure that they have, everything's been ruled out. It's like, again, I know the limitations of my scope of practice, and I'm not trying to do more than what I can. I'm really looking for those patients who haven't had any response to the typical treatment or what's been shown to work for these conditions, and now we've identified them as, I don't know what else to do with you. I'm really sorry, and can we send you somewhere else? Now, some of these patients go for behavioral management, you know, a large amount of them. So I understand that as well, and we've had to refer patients back to gastro because of that. Because you're not eating anymore, that's not a problem, you know? If you're not eating, I can't treat you because I don't want to get into that. So, then they appreciate it. The docs have been very receptive to me referring back because of multifactorial issues. But yes, we can set up an appointment, you know, come in and talk again. Like I said, I'm having a one-on-one meeting on Friday with one of the docs. I appreciate you guys coming out. Thank you very much.
Make sure you come up and get